it's sad that we prevented ourselves from knowing for whatever reason. But now we're picking up the baton of history, which is nice, but I don't want to sound too lofty about it. I'm hugely grateful for being able to do such interesting research, and it is fascinating research. I'm hugely grateful to be able to do something that may be clinically relevant and applicable and even deliverable. But some people get very excited about psychedelics and become quite evangelical about them, and I'm not one of those people. Because what clinical medicine and psychiatry has taught me is equipoise. You know, it's that constant state of wondering.
Welcome back to the Thinking Mind podcast.
Dr. Rucker, thanks very much for coming on the program.
A pleasure. Thank you for having me, Alex.
And maybe just to start, I wonder if you could give our audience a brief background, your professional background, and maybe just a summary of the work you're doing with psychedelics at the moment. Sure.
I landed in psychedelics through serendipity and also intention. So I trained in medicine at UCL. I graduated in 2003. At that point, I wasn't dead set on becoming a psychiatrist. Actually, I was kind of set on becoming a psychiatrist by the time I graduated, but I wasn't as a medical student. I didn't go into medical school knowing that I wanted to be a psychiatrist. But I've always been interested in drugs and the brain and their facility to change the nature of our conscious experience. That absolutely fascinates me. It has done ever since I was a child, really. So when I went to medical school, I thought probably I'd be a neurologist. But I also found the sort of molecular underpinnings of disease fascinating as well. So one of the first jobs I ever had was as a cytogenetic lab technician in an oncology lab. And in particular, we were looking for this molecular signature of leukemia called the Philadelphia translocation, which has all sorts of downstream effects on treatment of certain types of lymphoma and leukemia. Forget now, my medicine is departing me in that sense. So anyway, I was always interested in molecular mechanisms. But then about halfway through medical school, I had a severe depressive episode. And it took me many months to recover from. And it was exceedingly disabling and very distressing. And it opened my eyes to the emotional aspect of my experience and how that was also being mediated by my brain and my body and the way I thought about all those things. This whole new sort of vista of insight, if you like, into what was going on in my head opened up. And I discovered that depression runs very, very strongly in my family. So I was very interested in that. Why was this happening to me? What was happening? And I was lucky. I got better with antidepressants, albeit with side effects. And I continued on in training in medicine and was pretty good. But that kind of skewed me away from neurology and oncology and into psychiatry. So that was kind of the reason why I went to psychiatry. So pre-existing interest in why drugs alter our conscious perception, how they alter our conscious perception, but also my own personal experience. I actually took I originally started as an A&E doctor. I trained as a A&E doctor for six months. Was it a year? I think 6 months. And then before switching to psychiatry, and that was very useful. It sort of taught me how to deal with all the sort of bumps and bruises and cuts and GP problems that we see as young psychiatrists on the ward. And then I started training at the Maudsley, and that was around that time was when the whole political reaction to Harold Shipman kicked off. And the then health secretary at the time, called it was Patricia Hewitt, I think, essentially panicked about the Harold Shipman case, and the panic reaction was to impose far more bureaucracy on medical training.
For those who don't know, the Harold Chipman case. It was I believe, a doctor who was intentionally prescribing dangerous medications to his patients, and a lot of patients died as a result.
Yeah, but he also manipulated those patients into changing their wills in his favour.
Oh wow! Okay.
So he was essentially a sort of narcissistic psychopath in many ways. I mean, he's now dead. He killed himself in prison. I mean, what's fascinating about that case is that I don't think that there was any way really of detecting him a priori. Many of his patients loved him. Anyway, I mean, it's the sort of case that makes the machine worried.
Very disturbing.
Yeah, it's very disturbing. The upshot for me was I was caught as a cohort in what was called the lost cohort of SHOs. We were right at the end of our SHO training. We were forced to reapply for our own jobs whilst at the same time doing all our MRC Psych exams. And the upshot was that I passed my MRC Psych and was then shifted into another rotation up in Oxford where I didn't want to be, doing an SHO job or the equivalent of an SHO job I didn't need to do because I had the MRC Psych. So, I mean, I'd always been interested in research and academia, so I applied for an NIHR BRC fellowship back at the IOP, which is a year preparatory fellowship, buys out your salary and allows you to pursue a research project. And I got one of those, and that allowed me to work up a PhD fellowship with the Wellcome Trust. And I got that. And that was under a chap who's now retired called Peter McGuffin. He used to work at the National Affective Disorders Unit. So I did a PhD with him actually in the genetics of depression. So very data-driven, computer-orientated PhD where I didn't see many patients. And at the end of it, much as I have huge respect for that data and the power of it, I needed something that was more clinically focused. I felt I'd grown away from patient contact, and patient contact in psychiatry is very satisfying when you help people and they get better, particularly in conditions like depression where they really want to get better, they feel awful. So I took a year off, went travelling around the world after my PhD, and just had time to read and think and talk to others and experience different cultures, and came
Take
across
a step back from it all.
Yeah, exactly. Do a bit of soul searching, I think. Always good to do that in your career, I think. If you can take a break, no hurry to get to consultant status. I mean, some people are in a hurry because they want the money and they've got kids and they've got responsibilities. I didn't have that then. So it was a good time to take a break. Anyway, in my travails, or my travels and travails, I found what David Nutt was up to. And David Nutt at that point was just setting up his first psilocybin trial in treatment-resistant depression. It was led by him and then Robin Carhart-Harris, who's a psychologist over at Imperial. And essentially I was offering my time for free because as an SBR you get 1 day a week to do research and special interest. So for the next few years I go over to Imperial and give my time to them for nothing, which is very valuable to them because they'd run out of money on the grant for various reasons. So I ended up seeing a lot of the people, a lot of the patients with depression who were then given psilocybin in this pioneering pilot trial, really. No one had done this. It's quite exciting.
And psilocybin is the active ingredient in what's known as magic mushrooms.
Yeah. Psilocybin, classical psychedelic drug, found in mushrooms that grow all over the world, all over the UK, out about now, in fact. But if you pick them, you're committing a criminal offence. And I think I can't remember if it was 2015 or 2016, but some point around then, I signed a prescription, which was the first legal prescription for psilocybin for a patient with a mental health problem since 1970, since Prohibition, essentially. And on we went, and we did that study, and it was an open label pilot study. So those studies are not designed to prove efficacy. really not designed to prove anything other than the fact that you can deliver the protocol. You can do it in principle. You demonstrate it.
Does it demonstrate safety, like medical safety?
Yeah, it gives you an idea of safety, but because you don't have a control group in those studies, you don't have a baseline adverse event rate. Mm-hmm. And actually, that's what regulators are very, very interested in. They need a baseline adverse event rate for the adverse events that occur sort of naturally in the course of the disease process. But then they also need the comparison with the active treatment, which is placebo. And that trial didn't have that because it was just an open label pilot. It's just about can we fit this treatment paradigm into the clinical trials process at all? And the message from that trial was, yes, we can. So I was coming to the end of my SPR training by this time. I had a PhD. I suddenly realized, God, I probably a clinician with the most experience almost of giving patients this treatment. There are a couple of other people that have experience too, but they didn't have PhDs. So it put me in quite a unique position. So I wrote an NIHR Clinician Scientist Fellowship application, and they're quite prestigious fellowships. They hand out about 4 a year. They're competitive across medicine. So you're competing with every other doctor who has a research idea. And they're great because they buy out your consultant salary for 5 years and also give you the money you need to do a small trial and also give you the money you need to do any training. So I spent 18 months working up that application, and I think no one was more surprised than me to get it. And they grilled me at interview, and I thought I wasn't going to get it because of the grilling I got at interview. But I did. So that allowed me to come back to King's and set up my own study. And that in turn attracted a UK-based life sciences company called Compass Pathways to King's. So Compass was set up in about 2016 by a husband and wife called George Goldsmith and Katerina Malievskaya. And they had started to produce GMP psilocybin. So what do I mean by GMP? I mean the standard required for a medicine. It stands for good manufacturing practice. Every drug that we prescribe has to be produced to those standards. So we'd, in the Imperial trial, managed to persuade a company in Germany to produce it. And it was the reason why they had no money left in their grant was because they'd spent 3 years getting the drug into the country, produced to the right standard and into the country. So now here was Compass, a UK-based company, making the drug. Suddenly, all of the bureaucratic problems surrounding getting a Schedule 1 drug, I'll explain what Schedule 1 is in a minute, getting a Schedule 1 drug into the country were removed because the drug was being produced in the country. But more than that, and this is the critical point, they were producing matching placebo capsules. So that meant that we had a supplier that would produce capsules where neither I nor the patient would know whether they contained psilocybin or placebo. Of course, such things can become obvious during the course of the event, but the point is that it allows you to do those placebo-controlled trials that are necessary for licensing of a new treatment. So at that point, Compass were interested to fund us to do a further phase 1 trial in which we compared placebo 10 milligrams and 25 milligrams of psilocybin in a randomised controlled design. And we did that in 89 participants and completed that 18 months ago now. And
was that to establish efficacy for treating depression?
No. That was a healthy volunteers trial in patients, and it was designed to investigate safety.
Yeah.
And that's what randomized controlled trials in healthy volunteers are really about. It's to investigate safety. And I presented a poster about that a year ago at the ACMP, psychopharmacology conference over in the States. And we basically found that the safety profile is pretty good. you get all of these expected psychedelic effects. They are pretty much dose dependent. But for all of those effects, the vast majority of those effects that people report, they're gone by the next day. And of the events that people report subsequent to that initial psychedelic experience, the vast majority are positive. So about 95% of the mood events that people reported were positive rather than negative. So that's an interesting observation, suggests that there's something going on, albeit in healthy volunteers, that may be applicable to treating depression. Of course, we also had the pilot trial from Imperial in the treatment-resistant depression population, which suggested quite profound improvements, although it wasn't a controlled trial. So, it was expected in the sense that there would be quite profound improvements. So now that allowed Compass, on the back of that trial, to move on to their phase 2B inpatient, multi-site, randomised, controlled trial of psilocybin in treatment-resistant depression, and that's what we're doing now. We are dosing at the moment in that trial. And at the same time, the NIHR gave me money for my own trial, which for various regulatory reasons and the pandemic and all the rest of it still hasn't started, but such is the way with clinical trials. So that's where I am now.
What's your experience been treating patients with depression with psychedelics, just from the clinician's point of view? How have you found the process? Do
you mean, are you asking whether I think it's effective?
I guess I'm just asking, you've obviously treated patients for depression with conventional treatments just as a psychiatrist, and you've also had the opportunity to observe psychedelics in action in combination with psychotherapy. And how do you observe the patients going through that process? Does it seem importantly different? And if so, in what way?
I would say that the participants in the trials are pretty different to the patients I treat in the NHS. And that is an age-old problem with clinical trials. And people complain that clinical trials are not representative of the real world. And they're right. They're right. And it's not that we don't want to do those trials. It's that they are often impractical to do. So people with sort of really real-world treatment-resistant severe depression, they can't volunteer for trials. Sometimes they don't have the capacity. Oftentimes they're just logistically unable to do it. So we end up getting a slightly rarefied sample in our trials process, which means that my experience of treating people with psilocybin is not directly comparable to my treating patients in clinic. My observation of the clinical trials with psilocybin is that it's very early days to make any sort of predictions. I think that some people do incredibly well, but I would temper that observation by saying that when Prozac was first developed, some people did incredibly well with Prozac who had been treatment resistant for years. And the reason is the powerful placebo effect of the new powerful drug that's being tested for its amazing potential advantage in treating depression. That has a huge effect on someone's outcome. So I think it would be premature to say whether or not psychedelics are either efficacious or effective. Those are two different things. And the data will speak for itself. It brings into play, though, the idea of context, and the contexts within which we prescribe psychedelics are very, very different to your standard outpatient clinic or your standard GP surgery. And I think we need to consider this treatment within the distinction between those contexts.
Mm-hmm. I suppose one important difference is that you are pairing the treatment with the psychedelic with psychotherapy. And as far as I understand, it's both. You have therapy sessions before being administered a psychedelic, and then a few sessions with a psychedelic, and then a few sessions after. Is that right?
Yeah, let me explain. So generally speaking, in our trials, if you volunteer and you're accepted for the trial, you get introduced to a psychotherapist who will be your, I say guide, but they will be with you through your experience through the trial. Therapeutic consistency is important, and they will see you for a minimum of 3 hours prior to you being randomised to receive one or other dose of psilocybin. That psilocybin experience is just a single dose at the moment. You will come into the centre for that experience, and you will be there for about 8 hours. So you come in about 9 in the morning, and you're usually ready to go home by 5. The therapist will be with you throughout. There will also be a nurse and a chaperone on hand and a doctor on hand, sort of ready to provide support if necessary. And every person that we've given psilocybin to so far has been ready to go home by the end of the day. So that's part of the test, is can you deliver it without keeping people overnight? If you have to keep people overnight, it makes it much more expensive and logistically difficult to do. Every person so far we've sent home either at sort of 5 or between 5 and 8 in the evening. And then after that, we see the person the next day, and they have a further 3 psychotherapy sessions with their therapists to help them integrate whatever it is that they've experienced, which of course may be nothing in a placebo-controlled trial. But that's a challenge as well. So yeah, it's a package in which the psilocybin therapy is wrapped up with psychotherapy and a safe and supportive context.
Is it a particular kind of psychotherapy that's delivered?
Yeah, that's an interesting one. I mean, it draws on what was done pre-prohibition. So we are informed by people who are still alive now who used to do this in the 50s and 60s. And then also essentially a process that teaches people to relax, let go, and be open about their experiences. It draws on elements of mindfulness, acceptance and commitment therapy, and tries to allow the process of reorientation of perspective on difficult emotions, memories, experiences, as a way of building something more positive in the future. So it's not in that sense, it's very different to antidepressants, where we're kind of wanting to obliterate the feeling entirely almost, or obviate in some way, mitigate in some way. This treatment is more about how do you think about that, and how might that be playing into making it worse or making it better. So it builds on this idea of psychedelics as not being therapeutic agents in and of themselves, but as almost being catalysts of mentally salutary change within the right context. And that context being feeling safe and supported and in a ongoing psychotherapeutic relationship with someone you trust.
I mean, that's quite... That really does suggest that, psychedelics are an opportunity to rethink mental health symptoms and mental illness, in the sense that, as you just outlined, in this paradigm, we're not thinking of symptoms as an annoying or distressing experience in our subjective reality that needs to be eliminated, but rather an indication that something is wrong and something needs to be reprocessed, thought of in a new way, challenged, that some kind of growth or integration needs to occur. So, in a subtle way, this new form of treatment is really quite subversive, I suppose, in the sense that it invites one to rethink the conditions that we see every day.
Yes, I think that is true. And look, I'm not saying that that mental illness doesn't exist. It definitely does. I think of myself back when I had my severe depressive episode. I'm not entirely convinced that psychedelics would have been appropriate for me then. This is not meant to be a replacement for anything that we have, but it may be an addition to what we have. And I think from my own experience, what I found was that the antidepressants certainly did help me to feel better, but they didn't change the way I thought about emotions. And actually there was a problem there. There was a problem with how I was almost pathologizing my emotional state, and I was making it worse for myself. And I think therein is the opportunity both of psychotherapy in general, but also the attitude that we bring as psychiatrists and as doctors towards mental illness, and how that is received by our patients and the context in which we deliver a therapy. And if we are delivering something that both mediates a change in the underlying emotional state, but also gives someone a toolbox that they can take away with them to change how they think about it, then that's probably quite a powerful combo.
Yeah, I think in psychiatric training, there's a gap where we don't think about emotions as something that, evolution has given us as human beings as a radar system to detect when things aren't right. But, as you said, their extreme emotional states are often just pathologized. And of course, that's not to say that mental illness doesn't exist.
Yeah, exactly. I think the problem is that by the time a lot of people get to see an NHS psychiatrist, they've been down a process almost that necessarily is pathologized, this emotional state that they're struggling with. And it starts with them. It starts with the patient deciding to go and see a doctor, and that brings up the whole sort of sociocultural question of how people behave in response to distress and how that is socially mediated. And so, I think in order to change that, you probably have to start at school. You probably have to start with sort of early years education about how parents teach their kids about how to deal with this distress. But that given that everyone is different, there are always going to be situations where people, for one reason or another, pathologize their distress and end up seeing psychiatrists. And of course, some of them have mental illnesses that will respond to medication, and that's what they want. And that's fine. I don't have a problem with that. It's just from my point of view as a psychiatrist, and in my NHS work, I work at the National Affective Disorders Unit. So we see tertiary referrals, and you see people who have tried many, many different treatments. But many of them are Me Too. They're Me Too treatments. They're all trying to do the same thing, which is to sort of sit on this unpleasant mental state that the person is distressed by, and it's not working. So in that context, you could perhaps understand why considering something like psychedelics and psychedelic-assisted therapy that changes the way you think about things may be clinically very valuable.
The other thing worth mentioning, of course, is that we're at a point in psychiatry where there's been a lack of new medication developments for some time. As you mentioned before, psychedelics were used many decades ago before they became Schedule 1, which means essentially that these drugs aren't thought of in the eyes of the law to have any kind of therapeutic value, but may pose significant risk to the patients. And now, we're at a point where obviously there's a huge resurgence in interest in psychedelics, and I think I don't think it's a coincidence that at the same time we're seeing a general public that's a lot more interested in mental health, that's a lot more in questioning the paradigms that we've been using. Do you feel that you're in an important moment in history in terms of psychiatry, the way we think about mental health? I understand that seems quite lofty, but part of me has been thinking, particularly during the times of COVID-19, I think we're more aware than ever before that we are a part of history.
Yeah, but of course it was the same for everyone. To imagine that some people felt the same when prefrontal lobotomies came into play, and how that turned out. So, I'm not comparing psychedelics to prefrontal lobotomies, obviously. I'm just saying that if you come across something that seems to be an advance, you can get quite excited about it, and that is definitely the case with psychedelics, and it's also a reflection of what psychedelics represent in society, particularly, what I would argue is the failed war on drugs. And psychedelics were caught up in that. There was no reason for them to be put in Schedule 1 and Class A of the 71 Act. But they were essentially because of the war on drugs and the Vietnam War and all of the sort of cultural problems that represented. I think that if they hadn't have been, if there had been a more informed and less knee-jerk moral panic reaction to what happened in the 60s to drugs like psychedelics, MDMA and cannabis, we would be much further forward in psychiatry. I do think that, not because I necessarily think they represent major treatment advances, but simply because drugs are a good tool for understanding what is going on in the brain. And it's true to say that the sort of classical psychopharmaceutical pipeline has run dry. We've had ketamine recently, but again, that's an old drug being repurposed. We've had another sort of Me Too drug, vortioxetine, and then agomelatine before that as antidepressants. Fine, but again, it's sort of variations on a theme, and I just wonder whether those underlying themes might have been a bit more creative had we not had this legal guillotine essentially come down on research with cannabis, psychedelics, and more latterly MDMA. And all of those drugs now are being picked up, 50 years later. So then the question is, well, had we not, as I say, brought the guillotine down 50 years ago, presumably we would have been doing that for the past 50 years, in which case probably we would be further forward in our understanding about how drugs interact with the brain to produce different states of consciousness. And I think that's fascinating. And it goes back to what I said before about why I do all this. And I just think it's sad that we prevented ourselves from knowing for whatever reason. But now we're picking up the baton of history, which is nice, but I don't want to sound too lofty about it. I'm hugely grateful for being able to do such interesting research, and it is fascinating research. I'm hugely grateful to be able to do something that may be clinically relevant and applicable and even deliverable. But some people get very excited about psychedelics and become quite evangelical about them, and I'm not one of those people. Because what clinical medicine and psychiatry has taught me is equipoise. It's that constant state of wondering what's going to work.
It's very Zen-like.
Yeah, well, when I got this fellowship, I sat down with Alan Young, who's the chair of mood disorders at King's and who's been supervising me and has been a mentor for some years now. And he sat down and in his very sort of dour Scottish way, he said, James, you need to be very Zen when it comes to clinical trials. And he didn't mean clinical trials with psychedelics, he meant clinical trials in general. And God, was he right. And
science in general.
Well, yeah, clinical trials in particular. They are wrapped up in so much bureaucracy and regulation. You think it's bad in the NHS, you see what it's like for clinical trials. And you know what? It's necessary because you're testing new treatments. Safety is paramount, and I absolutely understand it. But it means that my NIHR psilocybin trial has been in setup for 3 years. I haven't dosed anyone. It's been 3 years in getting all the permissions and contracts and everything else sorted out, money. So, yes, there is a certain zenness about me. That incidentally doesn't just come from Alan Young telling me to be zen. It comes from spending 2 years learning to meditate, which I would say is as much a valuable tool for my own emotional well-being as anything else.
I think, if I may say so, I think you might be the perfect kind of personality for psychedelic research, because I imagine in the minds of maybe the general public or people who are more skeptical, that there is something a bit threatening about psychedelics in that they can rapidly bring on such a powerfully altered state of consciousness. And to hear someone who's so measured, who's so sort of careful and precise in the way that he speaks, it really, you get the sense that there's a lot of scientific rigor, which is exactly what you would want to act as a sort of transition between these drugs being sort of recreational Schedule 1 to actually a legitimate medical treatment.
Yeah, I think we need to do it in a way that is whiter than white, because we are essentially challenging 50 years of stigma and legal opprobrium. Fascinating, because the money that pays my salary comes from the UK government, so they're essentially they're paying me to challenge their own drug laws.
Well, it's nice to know we live in a society that can do that.
I know, and I fully agree with you. It also makes for an interesting line of research for me. But I'm just aware, from my own personal experience of what worked for me for depression. Antidepressants was just the start. I had 3 years of psychodynamic psychotherapy, hugely powerful. Left me with realizations that shattered my foundation of myself, but allowed me to rebuild, in a safe and supportive context of that psychotherapeutic relationship. And then meditation and mindfulness, again, hugely important in allowing me to sit with distressing states and not spin them in my mind into something more than they were. Hugely important and valuable. Regular exercise, yoga, good diet, social connection, all of these things, so important in the treatment of depression. So for me to come and start to eulogize about psychedelics would be a rejection of that, of all of those other things that actually are already there now, available, and very important for me.
Yeah, and certainly we're learning about the value of social connection now more than ever, where it's illegal for people of different households in some parts of the country to socialize with each other. And I worked in a crisis team during the peak of the initial first phase of COVID, and it was remarkable just to see presentation after presentation of an acute mental health crisis precipitated by nothing more than just feeling so isolated and seeing firsthand just how bad that is for us.
Yeah, I think even in psychiatry, even in sort of secondary NHS psychiatry, most of the problems we see don't need to be medicated. They need, a calm, friendly voice and a holding hand. But we almost have been professionally brought up to reject those sorts of things, or at least the machine around us doesn't favour that sort of intervention because it takes time. Of course, 50 years ago, we had much more time in psychiatry than we do now. And I think it's up to us as psychiatrists to resist those efficiencies of economy that we appear to be subject to, but we're veering away from psychedelics and more into more general sort of psychiatry. But
I always felt that I have quite a strong interest in meditation, and from my meditation practice and reading about psychedelics, I always felt that although they're not identical processes, they seem to some degree to be pointing in the same direction. And the commonalities I can think of are that they both seem to, at very different rates, cause some sort of altered state of consciousness. There's an idea of a more expansive state of consciousness, an idea of self-discovery, an idea of becoming more familiar in a very first-person sense with your thoughts and your emotions. Is that how? What was your sort of journey through meditation like for you, and how did it help you deal with the depression, as you mentioned?
It taught me that my mind sort of thrashing this way and that was a message of underlying stress and distress that I was building a wall around, and behaving in peculiar ways and interacting with people in peculiar ways as a manifestation of that. And it's allowed the time and space twice a week, each week, to check in and say, how are you? What's going on? And just pay attention to what emerged. It brought up all sorts of philosophical questions about whether I'm in control or not, which brings up the whole free will thing, a whole different podcast, I guess. And I just realized that, to a certain extent, my brain is running on autopilot, my body is running on autopilot, and I needed to learn to listen to what it was saying and learn how to relate to that in a way that was productive and positive, rather than in a sort of neurotic, catastrophizing, negative way. So it was something about space, about allowing myself the space in my week to perform a process and develop a process that was helpful overall to my mental health. And to do it in a context, I used to go to this centre in Clapham, and to do it in a context where other people were doing that too. And we would talk about it afterwards, and there would occasionally be talks about it. So it was just, it was a form of psychoeducation, both coming from out there and going on in here. And of course, it reflects some of the things we're trying to do in psychedelic therapy. So I didn't understand it as a preparation for what I was going to do in the future. I had no idea I was going to fall into psychedelics when I learned to meditate. But sort of looking back, it was part of the puzzle of how to fit into this particular field and to take it forward in a way that retained a certain form of equipoise about what was going on, what were the underlying drivers of therapeutic change, if indeed there was therapeutic change. And it's complex, very complex.
Yeah, it's certainly complex, if nothing else. I think, so you outlined that meditation kind of introduces you to a process of less control rather than more control, and perhaps a reduction of resistance to whatever is going on with you, both sort of in the internal world, your thoughts, your emotions, etc. But I suppose also things which are happening around you. And I guess when you were talking about the psychotherapy that's combined with psychedelics earlier, that was kind of a theme as well. There's an idea of a letting go and a dropping of resistance. I think many people who struggle to see the value of something like meditation, like how can I have an altered state of consciousness? Is it even possible to have an altered state of consciousness? Perhaps psychedelics can be a fast-acting introduction where all of a sudden their perspective is shifted, and then they can then fall back on meditation as a more longer term, gentler maybe way of studying themselves.
Yeah, so it brings up again that question of who would potentially benefit from this treatment. And I'd say to start off with, you have to want to change, and you have to want to go down the hard road of change. I think when I was sort of severely depressed as an undergraduate, all I wanted was to feel better. And in that context, antidepressants were quite helpful. But they were glossing over cracks, and they weren't addressing the sort of foundation of how I was thinking about myself and my emotions. And I don't think they'll ever do that. Psychotherapy started to do it. But again, I think I became interested in what was going on. I wanted to understand why and what was driving this in my mind.
So you're an active participant.
Yeah, I was open to the idea that it was a biological process, but it was also a psychological process and a social process. So I think in order to be receptive to a change in perspective, you need to have that sort of underlying intention of accepting a different perspective. So it's not as simple as saying you take a psychedelic and it changes the way you think about things, because that brings up this idea of the psychedelic doing it for you, and it's not about that. It's about you wanting to know and wanting to change, and I think that is critical. Mm-hmm. And I mean, we often have a sort of clause in our trials where we basically spend a number of weeks getting to know people, and if we don't think they're ready for that, then we won't give them the drug, because it's not ethical in that circumstance. To give something that can potentially be so challenging to someone's underlying perspective, if they're not ready to engage with a process of change that may be very therapeutically and emotionally uncomfortable for a while.
And of course, that's even an approach that's adopted in psychotherapy without any psychedelics, where if you're talking to a patient and the therapist is always asking themselves, what kind of psychotherapeutic challenge is this patient ready for? Am I going to lean on the side of being too challenging or too comforting in the session? And where is actually the zone of proximal development where you can challenge the patient in a way that's, stimulating, but not in a way that's so much that it totally overwhelms them? Yeah.
And I mean, that brings up such a complex process of interplay, dynamic interplay between therapist and patient, and then you add a psychedelic into that mix, and it is an additional element of gamble, I think. I do tend to think about psychedelics as a little bit of a gamble, an informed gamble, but a gamble nonetheless. And that just underlies, again, the importance of set and setting, of people being prepared and educated, of wanting to change, but also trusting who they're with and feeling safe and supported where they are.
Given that, we're just talking about the use of psychedelics or the potential use of psychedelics for conditions like depression, we're veered towards themes of integration, growth, discovering new things about oneself. Do you have an intuition, therefore, that psychedelic-assisted psychotherapy might be useful for conditions such as personality difficulties? I know that they're already being researched for trauma in the United States, or at least MDMA is being researched for trauma. But do you have an intuition about their potential use for personality difficulties?
Yeah, I'm not really terribly keen on the concept of personality disorder, but that's slightly, you said difficulties, probably intentionally. The simple answer is yes, so long as you sort of genuinely want to change, and are not sort of subconsciously invested in staying the way you are. Although, how would you know that? I think it's just I think with certain types of personality difficulty, that there's an added elements of complexity where I'm not yet sure whether putting a psychedelic in the mix is wise, or whether it might need to come after a more extended period of psychotherapy and preparation. And of course, this is the way psychedelics were used prior to 1970. They were used in the context of often long-term, dynamic and analytically informed modes of psychotherapy, perhaps every 3 months or 6 months, occasionally more frequently than that. So I think the answer to your question is yes, but perhaps it doesn't fit so well in the paradigms of trial design that we have at the moment, and which are quite constrained essentially by funding. We can't afford to give people endless psychotherapy sessions in a clinical trial, and it also introduces problems into what is causing what. Psychedelics don't fit easily into clinical trials paradigms, particularly the RCT paradigm that attempts to separate drug from context. It's a very general problem in psychiatry and in medicine. I mean, we hardly ever prescribe a drug out of context. I think there are certain key things you need to look for in someone, before you give them a psychedelic. So we're also always quite careful about looking for personal histories of psychotic reactions or psychosis in the family. Because psychedelics were initially thought of as essentially psychotomimetic drugs, so sort of inducers of a model psychosis. In some sense, I think that's accurate. It's only one element of their broad effect, but they do seem to induce an almost dreamlike state, which I sometimes recognize in people with chronic psychotic states. So we have to be careful. We have to be judicious about who we use them with.
So if you've had, a history of psychotic episodes or a family history of psychotic episodes, then these drugs probably aren't a good idea because of the possibility that they could cause a psychotic episode. Is that right?
Yes. Yeah, I think so. There was some research from the 60s that really suggests that if this risk is there at all, that it's pretty slight. Nonetheless, I don't think we would ever give psychedelics to someone with an established psychotic disorder. I can't see that happening. For people with a family history, I think you have to be very careful. I'm not ruling it out, but you've got to get your foot in the door with these drugs from a regulatory point of view. I sort of recognise the degree of stigma there is out there against them. And the treatment-resistant depression cohort is from a sort of drug development point of view, the low-hanging fruit, because there are so many people with depression that doesn't get better with standard treatment. Probably 100 million people around the world in that sort of position. So, and that contributes to a huge amount of socioeconomic activity, personal distress, carer burden, all of these things. So from that point of view, governments and medicines regulators are prepared to engage with something like psilocybin therapy on that basis. There's so much unmet need there. The existing treatments we have, like lithium and ECT and long-term psychotherapies, are often very stigmatized or have side effect burdens that are unacceptable, or are just very expensive to deliver. Long-term psychotherapy is expensive. So in that context, I think we can make a case for developing something like psilocybin therapy. But when it comes to things like personality difficulties, bipolar disorder, other disorders, each time we're going to have to make a case for that. But given that sort of fundamental paradigm of shifting perspective on things that are difficult for you, whatever they may be, potentially that's quite broadly applicable. And if we get a license for treatment-resistant depression, I think it will give us a certain certain creative leeway in how we take the treatment forward.
So at what stage is your trial at now, and are you in a position to talk about any of the data you've accrued so far?
So we're midway through the trial, and the short answer is no. And the reason why is, well, A, I wouldn't, because it would be jumping the gun, but B, we never see the data. So the way it's actually the primary outcome, the changes in depression rating are collected by someone who's completely separate to our team. They're actually based in another country. They phone the person up and they very sort of dogmatically go through these questions about depression. They're completely blinded to status. They tell the participants not to stray from the questions, and especially not to discuss the treatment they think they may or may not have had. And in that way, you mitigate some of the problems of blinding and bias that can come with psychoactive drugs, where you may think you know what you've had through the subjective effect. So I don't get to see the data, and quite right too. In fact, no one really gets to see the data until it gets to the statistical analysis, and even then they do not have data pertaining to allocation. So they'll have, this person was in group A and this person was in group B and this person in group C, and they analyse according to A, B and C, but they don't know what A, B and C represent. And it's only after that analysis has been done, double-checked by an independent statistician and locked down, that we find out what A, B and C represent. And that's the way good clinical trials are done to mitigate bias, and that's the way the multi-site TRD psilocybin trial is being done.
Mm-hmm. And is it correct that the clinical trials investigating the use of MDMA for PTSD in the States, is that now in phase 3?
It's in phase 3 in the States. They're also bringing that research over to Europe, essentially to try and replicate it in Europe, because the regulators have asked that they provide evidence of generalizability beyond the United States if they're going to secure licensing beyond the United States.
And do you happen to be familiar with what kind of results they've gotten so far?
Yeah, well, there's an aggregate analysis of the phase 2 trials. So just to tell people that MDMA psychotherapy, it's very similar to psilocybin therapy in many ways, except that you're using MDMA. MDMA is an amphetamine that essentially induces a large release of serotonin, and it mitigates particularly the amygdala response, the fight or flight response that seems to be particularly problematic in post-traumatic stress disorder. So existing treatments for post-traumatic stress disorder are appalling. Medical treatments, that is, psychotherapy fares better. EMDR, that sort of thing, fares better. But medical treatments for PTSD, like sertraline, they do not perform well at all. So the MDMA for PTSD trials, let me try and remember, there was an aggregate analysis that showed that, I think it was 3 months after the therapy, or at the primary endpoint of the, which I can't remember when it was, maybe a couple of months after the MDMA sessions, 2/3 of people, and these people had chronic treatment-resistant PTSD, no longer met criteria for PTSD. And that what was more interesting actually than that was that a 12-month follow-up, not with any other treatment, but at 12-month follow-up, that proportion had slightly increased. So more people at 12-month follow-up, despite having no further treatment, more people did not meet criteria for diagnosis. I think it was something like 69% versus 62%. So maybe not statistically significant, but interesting nonetheless. And again, it's, the therapy is about perhaps for the first time being able to sit with your trauma and the emotions associated with your trauma and say, wow, there you are, hello. Can we form a relationship because you've been bucking me for a long time? It sounds very cheesy, but that sort of thing can be powerful.
Mm-hmm. In trauma, they often speak of the idea of reprocessing. So taking a traumatic memory and reprocessing it so that it no longer... Because the problem is a traumatic memory, when activated, essentially gets you back into the present where the trauma happened. And the idea is that's why it activates that fight or flight response. All of a sudden you're back in the trauma, something very bad is going to happen. And of course, this could be activated by something in the environment which isn't a potential trauma, but is just a reminder. That's why people are hypervigilant, or they have an exaggerated startle response. You think of like a soldier hearing a loud, high-pitched noise in a supermarket, all of a sudden he's back in Iraq.
Yes. But sometimes I think the fundamental problem there is the fact that you've been so walled off to that horrendous initial experience that it simply hasn't been possible for you to sit and look at, the nature of that experience for any significant length of time. And when it does happen, the response is exactly the same as it was when the initial trauma happened. And the MDMA is about mitigating that response to the extent that it is then able to be engaged with for a little bit longer and thought about for a little bit longer. And that has the capacity to sow a psychological seed of reintegration, of bringing the trauma out into the open, reprocessing it, accepting it, and ultimately moving on from it, whilst always recognizing that it is a part of you and a part of your history.
Mm-hmm, mm-hmm. And of course, a lot of other conditions besides PTSD are now starting to be thought of through a trauma lens. So they're starting to think about depression through like a trauma lens, like what traumatic episodes may or may not increase your likelihood to develop a depression or a psychosis or personality problems.
Yeah, absolutely. Yeah. I mean, all of these diagnostic strata, they're so arbitrary. And I think, often there is I'm sure there's an underlying genetic element to predisposition, but often there is, after a while, in many people, identifiable trauma that they might not identify as being trauma to start off with, but actually when you start to unpick it, these themes occur again and again, which are similar to an underlying traumatic theme that happened to them when they were a child or an adolescent. Maybe they were bullied over an element of their self-identity, and then that impacts on their the relationships that they seek out as an adult that keep failing, and that's what makes them depressed. All we see is the depression. Actually unpicking that process, you get back to a process of being victimized for an aspect of your identity that was nothing to do with you. You were born with it. And therein lies the nub of much of what we see in psychiatry, but often don't have time to get into.
And it's amazing how subtle these things can be, the things which produce very powerful emotional responses in us when we're small children. Have you ever seen the still face baby experiment on YouTube?
No.
So the still face baby experiment, I would encourage everyone to go watch that on YouTube. You just observe a mom with her young infant, and the mom is interacting with her baby just as the way you'd expect, mirroring the infant's emotions. The baby is happy, and she's mirroring that happiness back, and they're having the exactly what you would expect. And then the mom is instructed to adopt a very, very apathetic, still face, essentially.
I know what you mean now. Yeah.
Yes. And within 2 minutes, the infant has no idea what's going on, and then becomes very, very emotionally deranged. And once you know that it only takes, a mom having a still face for 2 minutes to produce such a powerful emotional response. And you think there are so many reasons why, parents may have sort of some kind of abnormal interaction with their children. And it's no wonder that we do, as human beings, have this tendency to accrue these, even if they're not traumas with a big T, these low-level emotional traumas, which can really, affect us as we grow older.
Yeah, and I think it brings up, how then we respond to our patients as doctors and therapists, with these professional structures that we're expected to work within. And of course, they're there often for good reasons, with the idea of protecting us. But I think sometimes there's, those can have psychological impacts.
Yeah. And I mean, Carl Rogers, who I'm starting to read a lot of now, famously challenged that and said, as clinicians, Carl Rogers was a psychotherapist and prominent in the 50s and 60s, for those who aren't aware, and he advocated the idea of congruence. So whatever emotional reaction the patient produces in you in a digestible and in a professional way, you mirror that back to them. So you're not, as maybe Freud would have wanted, this blank slate that's totally emotionless, but rather you're giving the patient a constant emotional feedback in such a way that is actually helpful for the patient, that allows them to grow and develop.
Yes. And I think many people in principle would agree with that. But I'm thinking of my consultant colleagues in CMHTs who have caseloads of 800 patients, and how do you do that for 800 people? It just isn't possible. So it brings up this idea of how much time we have to spend with our patients and how emotionally available we can be, particularly given we all have, often psychiatrists come from places of trauma as well. That's the reason that propels us into mental health, but just that we have limited reserves of emotion that we can give. But I think it's still a very valid point. So one of them, there's a doctor working on my team called Camilla Day, who you might know because she's SPR at Wesleyan. She's looking at concepts surrounding self-compassion and whether or not these might have a mediative or correlative effect of improvement in psilocybin treatment for resistant depression. And of course, that reflects the idea of the therapist being compassionate and the team being compassionate, the doctor that you see being compassionate. And all of that is wrapped up into, if you like, a package as a whole. And it's almost impossible to disambiguate one from the other. And just brings into play the fact that really what we're testing in these clinical trials is a package. It's not just psilocybin. It's psilocybin plus, psychological support in inverted commas. It's more complex and fine-grained than that. And that all these clinical trials are really doing at the moment is establishing whether or not psilocybin is basically safe to give in these contexts. But they have difficulty in determining efficacy because of the fact that the psychological support we give regardless of whether or not we're giving people placebo or psilocybin. So disambiguating unpicking what the relative effects of each of those things are is very difficult. And I think if psilocybin therapy gets a license, then a much more interesting question comes up. And that is it deliverable within current healthcare settings? Will people pay for it? And is it consistently deliverable? And I think it's a far more interesting question for me, actually, and I think it's far more uncertain. I think it can be, but I think you need dedicated centres for it. And they're probably going to be centres that, they essentially represent a different paradigm of approach. And they have, you have much lower caseloads. Because then you then have the time to be able to devote to people that need that holding hand in order to inculcate change or provide a foundation for mentally salutary positive change. That in itself could be very powerful, and worth it from an economic point of view.
Yeah, I think it's fair to say that it's sufficiently different that it's probably become its own subspecialty within psychiatry, I imagine, because it's so particular.
Yeah, but you could see it. You could see it quickly becoming overwhelmed, you know, with a need and it would have to then start that process of building boundaries that may then create a problem in itself. So, you know, it's really tricky thinking about how it would all work in practice. But it doesn't detract from what we're trying to do. It's thoroughly interesting, and maybe it will work. We will see. It's an interesting trip.
yeah, I can imagine. And it's so, it just opens so many philosophical doors as well. And that's really the interesting, I think what draws a lot of people to psychiatry is what's the philosophy around all of these concepts we're dealing with every day. And really in every sphere of life, whether we're aware of it or not, there is an underlying philosophy which acts as that thing's operating system. So if you're a lawyer, you're operating under a philosophy of law that we happen to have in the UK in 2020. Often we've internalized the philosophies of people that have come before us, our parents, our societies and our culture. And it really feels like, again, psychedelics have this capacity really to challenge a lot of the philosophies which we take for granted and maybe introduce new ways of thinking about things.
Yes, I mean, some people say that's why they were banned. I don't think it was that nuanced, to be honest. I think the reason why they were banned was because they're essentially taken by hippies. They diffused into hippie counterculture, and it was the hippies who objected to the Vietnam War, and Nixon hated anyone who was against the Vietnam War because he saw it as an ideological opposition to his war against communism. So
it was a lot of things conflated.
Yeah, but I think the sort of idea that, you know, the political elite banned psychedelics because they recognised the power they had to challenge sort of societal constructs and deep philosophical conversations about where we come from as a species. I don't see much evidence of that, and I think it overplays the power of psychedelics, if I'm brutally honest. As I say, you've got to want to go there, you know. And if you don't want to go there, then I'm not sure psychedelics are necessarily going to take you there.
Yeah, and it's so important to, like you mentioned earlier, diffuse that evangelical approach. And even though we live in 2020 and we're so technologically advanced, we live in a very evangelical time, I feel, where people are very religious, in a religious way, attached to whatever their ideas are about how to make the world better or what they feel is important. And it's just getting worse.
I know. And that's why I try to mitigate that by not being too attached to psychedelics or anything in particular. And I think part of being a good psychiatrist is to help people find what's right for them, you know, because ultimately that's what they can take away with them. If they're taking away what you think is right for them, well, you know, you could be right, but you're probably not.
Mm-hmm. It's just another imposition.
Yeah, it's just another imposition. It's a reflection of an imbalance in power, and I think we should be deeply mindful of that. Particularly in the position that we are in psychiatry, where we're prescribing drugs that can alter people's states of mind, but also, you know, pertaining to the power that people perceive that we have. We need to be very responsible and beneficent, really, and benign, I think.
Well, James, I've taken up a lot of your time, but I always give my guests an opportunity to ask me a question at the end if they happen to have one.
Oh, you've thrown that one on me.
It's curveball, classic curveball.
Yeah. Well, okay. Do you think psilocybin therapy will become a medicine?
That's interesting because I asked you that question earlier, or in a different way, maybe. I certainly think it's possible. I think, like you, I'd want to see it borne out by the data. I certainly think it's possible partly because of the research that we've already seen in the United States, both with MDMA, but also there's some quite compelling research done by Johns Hopkins examining psilocybin for patients who had a terminal diagnosis. And just from what you hear about their patients' experience of this process, seems to be very promising. And, as you mentioned, a lot of patients feel this to be a very, very positive, but not just a kind of benignly positive, a kind of positive in a way that their perspective on the way they see themselves has been importantly shifted. And what I know from psychotherapy is that that's a very important point to reach if you want to achieve some kind of substantial growth. So if these medicines offer a safe and reliable way to do that, then I think then what would the barrier be other than, I don't know, people having a more conservative point of view? I can't imagine what the barriers would be if the scientific process was allowed to reach its natural conclusion and if it was, shown to be efficacious.
Yeah, well, the data will speak for itself, but I notice you use the word medicine, so I take that as an encouraging sign. We will see. As I say, it's an interesting ride.
Yeah, well, fair enough. Thanks very much for coming on the podcast. You're welcome back anytime.
Thank you.
You are listening to the Thinking Mind podcast.
If you enjoyed today's podcast, we'd love it if you share it with a friend, or you could give us a rating on Apple Podcasts, Spotify, or wherever you listen. If you fancy it, you can even buy us a coffee to support the team, and the links for that will be in the show notes. Thanks for listening.